Right. Good afternoon, everyone, and welcome to our educational kickoff webinar for our next maternal initiative, focusing on cardiac conditions. Today, we will be learning about avoiding catastrophic cardiac outcomes in pregnant and postpartum women. And as always, we wanted to thank everyone on the call today for your participation in the GAP QC and for everything you've done to help us get through this last COVID-19 surge. We really appreciate each and every one of you and know that we haven't had a webinar in a few months just to allow you all some breathing room, but really just thank you all for everything you do every day. Before we get started, I'd like to ask everyone to keep their lines muted during the presentation so that we can avoid any interesting disturbances. The slides and recording for today's presentation will be sent after the webinar and will also be located on Microsoft Teams for those that have access. We do plan to open up for Q&A after our presentation today, so please feel free to wait till the end where you can unmute your line and ask your question, or you can type your question in the chat at any time. Later in the updates, we'll have some information on how to submit your interest in joining the Cardiac Initiative, but please, you can certainly reach out to me directly. This is Lisa Ely, should you have any questions about joining the initiative. A few updates. Our next maternal webinar is scheduled for April 5th. We are going to cover two areas. One will be GAP QC's transition to REDCap for data reporting. We've gotten a lot of feedback on improving our data reporting process for efficiency and simplicity. So we'll be covering that transition, as well as be hearing from Augusta University Medical Center on their severe hypertension initiative with focus on their time to treatment efforts. Our next maternal data reporting submission is due Q1 2022, which is due on April 31st. Again, as mentioned above, we are going to be switching to reporting via REDCap, and so that new process will be reviewed on April 5th. So I encourage you, if your data person is not on this webinar typically, please do go ahead and invite them to that April 5th webinar. Our Q4 2021 hospital reports are uploaded to Microsoft Teams as of yesterday, hot off the press. And so I will send a link after this webinar with a direct link to access those, but you can certainly go to your hospital Teams folder to view those after the webinar. And then we have a tentative save the date for our GAP QC annual meeting, which is scheduled for October 13th and 14th, but we will keep you posted on plans once they are solidified. Okay, so today's educational webinar is to support implementation of the Alliance for Innovation on Maternal Health, Cardiac Conditions and Obstetrical Care Patient Safety Bundle. This bundle was released last August, but you're going to hear me reference the bundle as Ccoc, as it is a mouthful to say every time we're talking about the bundle. So you'll hear me reference it as Ccoc. I know that a good amount of you were able to attend the bundle kickoff webinar, which was last August, but if you were not able to make it and you haven't checked out the recording, all of the slides and the recording are available on Microsoft Teams within the Cardiac Conditions channel. And I'm going to talk a little bit more about our resources located on Teams in a bit. But really for today's purpose, we will briefly review key elements to the bundle. We'll talk about our timeline and we'll discuss our working group and subgroups and just briefly go over engagement opportunities before we welcome our wonderful speaker today. So this image you will be familiar with. Similar to the other AIM bundles, key components for the cardiac bundle include the 5 R's. So readiness, recognition and prevention, response, reporting and systems learning, and now includes a separate respectful care component that aims to integrate throughout each bundle element, throughout each R. So I am not going to be reviewing the bundle interventions in detail today. We are going to be hosting an implementation webinar in May, and we are going to do a deep dive into the key driver diagram, the outcome process and structure measures, and we'll discuss additional implementation details to support our enrolled hospitals with getting ready for bundle implementation. But today I'm just going to speak more broadly about each of these components to give you an idea of what we're looking at here. So the readiness component will focus on these 4 main areas and really addresses what is in place to ensure timely response. So the first area for readiness addresses every unit, and the bundle identifies units as all care settings and potentially including emergency departments, urgent care, and other practice areas where providers may not have specialized training in the care of pregnant and postpartum people. The second area is cardiac conditions screen. So this will focus on training all obstetric care providers to perform a cardiac condition screen, which is inclusive of a patient history of cardiac conditions, patient reported symptoms, vital signs, physical examination. So the third area for readiness is establish a multidisciplinary care team, and some may know this as a pregnancy heart team. Or consultants. So this is appropriate to your facility's designated maternal level of care, and really focuses on designing coordinated clinical pathways for people experiencing cardiac conditions in pregnancy and in the postpartum period. And lastly, for readiness, to develop and maintain a set of referral resources and communication pathways between OB providers, community-based organizations, and state and public health agencies to enhance quality of care. So the second element is recognition and prevention, and this applies to every patient. So recognizing the signs and preventing the crisis. So this element focuses on screening for community support needs and resources provided. So screening each person for cardiac conditions associated risk factors and providing linkages to community services and resources. And the screening should not just be medical screening. It should include mental health, substance use disorder needs, and assess for structural and social drivers of health. And then resources should align with the pregnant or postpartum patient's literacy level, cultural needs, language proficiency, and geographic location and access. So for the element of response, this applies for every event and really addresses protocols put in place to ensure better future outcomes. And this focuses on offering reproductive life planning discussions and resources, including access to a full range of contraceptive options, and also providing patient education focused on general life-threatening postpartum complications and early warning signs, including instructions of who to notify if they have concerns and time and date of a scheduled postpartum visit. For reporting and systems learning, this applies to every unit. This focuses on active learning from the data collected. So focusing on establishing a culture of multidisciplinary planning, admission huddles, and post-event debriefs, performing multidisciplinary reviews of serious complications, and reviewing your data, outcome and process data with disaggregation for race ethnicity to address disparities. And respectful care. So this applies to every unit, every provider, and every team member. This element focuses on a set of standard practices that would ensure an equitable encounter. So this focuses on inclusion of the patient as part of the multidisciplinary care team and engaging in open, transparent, and empathetic communication with pregnant and postpartum people and their identified support network to understand diagnoses, options, and treatment plans. And like I said, we're going to go into each of these elements in details, all of the interventions that are attached to the bundle and the May implementation webinar. So here is our timeline. As I mentioned, the AIM CCOC bundle webinar was in August of 2021. It was mid-August. At that point, we disseminated an interest survey to our hospital teams regarding the bundle and just determining who would be interested. And some reported yes, and some said maybe. So with that data, we then invited folks to attend the Cardio OB International Symposium, which was a fantastic conference. It was a weekend-long conference in October. From there, we created our cardiac work group, and it's a multidisciplinary group, and we are growing in our disciplines to really kind of mimic the bundle and creating that multidisciplinary team. And we are meeting monthly for that. And as you can see here in orange, that's today. We are having our Georgia Educational Kickoff webinar. The next plan is for us to do active enrollment and onboarding from April through June. And as I mentioned, in May, we will have our GAP-QC implementation webinar for our enrolled hospitals. Our plan is to begin data collection July 2022, provide ongoing technical assistance throughout bundle implementation, and we plan to have our first data submission Q3 2022. So that's July through September, submission October 31st, and that will be submitted via REDCap. So this is just a little bit about our multidisciplinary work group that was established in November. I have the specialties that are represented listed here. We have about almost 18, I believe, work group members at this point, and we are growing, always looking for representation from additional specialties. The work group decided there are specific bundle elements critical to initiating the bundle. It's a different bundle. It goes across multiple settings. And so the group decided that subgroups were necessary to focus on some key bundle elements to support our hospitals getting ramped up. And so primarily this is in the area of the bundle areas of readiness, recognition and prevention, and response bundle elements that really folks will need to have in place to sort of get going. And so you can see the subgroups listed here on the right. Each subgroup is identifying and creating key products in these areas to support our cardiac teams. So more to come on these products as we begin implementation. And a huge thank you to our work group and subgroups. So just to briefly describe the cardiac bundle engagement opportunities, this includes an active improvement cohort as well as a learning collaborative cohort. We know that teams will be in different readiness areas, and so we wanted to give opportunity to select where you are. And so for teams part of the active improvement group, they will need to identify project champions, complete a readiness assessment, submit quarterly data, and they'll also receive their quarterly hospital reports on outcome, process, and structure measures, and they'll receive improvement coaching support. For teams looking to be part of the Learning Collaborative, this looks like engagement in monthly webinars and meetings. There will be no data submission component, which also means they will not receive quarterly outcome, process, or structure measure data reports, and they will not receive coaching support. And just to break down a bit more for the active engagement teams, to give you a little bit more detail here, we hope at minimum teams will attend GAP-QC learning sessions, submit a QI report showing work related to the key interventions, complete an initiative-specific survey every 6 months. And this is what our hemorrhage and hypertension teams pretty much do right now. It helps us keep a pulse on what's going on in the state on the initiatives. And, you know, at minimum, submit at least 1 quarter's worth of process and structure measure data during a 12-month period. You know, ideally, we'd like to get the quarterly data, but at minimum, this data requirement would really be helpful. And then lastly, we really want to share what's working well to celebrate wins and to help other teams out in their improvement journey. So we really want to advocate for communicating and celebrating your impact that you're having at your hospital, and sharing that impact with the rest of the team. So we have started to build a repository of resources on Microsoft Teams, and so resources will continue to grow as we ramp up for the initiative and during the implementation phase. So we just want to be able to have resources here for every phase that you all will be working in. And if any of you have resources, tools, or instruments you'd like to share that you all are actively working on or have been using and that work well, please feel free to let me know or upload directly to Teams. These resources will be shared only with our GAP-QC teams, but we really want to create a robust repository for resources. And you may have seen this at our annual conference in October. This is a link to our bundle interest form. If you have your phone out, you can open your camera and hover over this QR code, and it will bring up the form. I will also send the link along with the slides after the webinar, but we will contact interested hospitals for enrollment beginning in April. And really thank you to all who have already completed the interest form and completed the survey in August. So we do have a list that we're actively working on as well. But for those that have not completed their interest form, this is where you would go. And again, I'll send that link out after this webinar. So just to recap, enrollment will start in April, followed by our implementation webinar on May 3rd. We encourage teams to access the cardiac resources on Teams to get yourselves familiarized with the bundle and the resources available there. And then certainly reach out to me with any questions regarding the bundle, or if you're interested in joining our cardiac work group. We would appreciate it very much. And so without further ado, I'd like to introduce our speaker today, Dr. Afshan Hamid. Dr. Hamid is a maternal fetal medicine specialist and a cardiologist at the University of California, Irvine. She co-authored the Interconception Care Guidelines from Ccoc in women with hypertension in the form of an algorithm to improve postpartum care and follow-up. She serves on the California Maternal Quality Care Collaborative, CMQCC, Pregnancy-Associated Mortality Review Advisory Committee that reviews all cases of maternal mortality to identify gaps in care for quality improvement opportunities. She co-chaired the Cardiovascular Toolkit and Venous Thromboembolism Toolkit published by CMQCC. Dr. Hamid served on the Ccoc Presidential Task Force for publication of Practice Bulletin on Heart Disease and Pregnancy in 2019. She currently served as an expert to help create obstetrics basic life support curriculum to integrate into the American Heart Association's life support program. She serves on the writing committee for Heart Rhythm Society's Arrhythmias and Pregnancy Guidelines released in 2020. And she also serves on the Society for Maternal Fetal Medicine's Quality and Patient Safety Committee. Her goal is to eliminate preventable causes of maternal morbidity and mortality. Thank you so much for being here, Dr. Hamid. You may go ahead and share your screen, which you are. I can see it perfectly.
Thank you. Thank you so much, Lisa. I would like to thank GAP-QC for this initiative. I think this is something that is overdue, to say the least. So thank you for having me. And over the next 40 minutes or so, I'm going to go over what we have learned so far and what the background of the cardiac bundle is. I have no financial relationships to disclose. The three areas that I'm going to cover are background on maternal mortality that you're all aware of, the AIM-CCOC bundle, and the Universal Cardiovascular Disease Risk Assessment. So with maternal mortality, the three questions, what is the leading cause, who is at risk, and when? We all know these are data from CDC. The trends in maternal mortality in the US has been on the rise. And when we look at the causes of pregnancy-related deaths, the cardiovascular conditions, 15.5%, cardiomyopathy, 11.5%, you add them both together, about 27% of maternal mortality due to cardiovascular disease. And I'm going to parallel that with the data from California because California has a large population and 1 in 8 babies that are born in the US is in California. So the California maternal mortality data is in the blue, whereas the United States is in purple. And we have been doing well in general doing very well in terms of maternal mortality over the last few years since the inception of CMQCC. Same goes for California. When we look at the causes of maternal mortality, the cardiovascular disease from 2014 to 16 is the #1 cause. And this has remained over the last few years as well. This is followed by sepsis, hemorrhage, hypertensive disorders, and pulmonary embolism. And if we combined the causes of cardiovascular death, 16% is cardiomyopathy, and other cardiovascular deaths is 12%. So 28% of maternal mortality is from cardiovascular disease. Who is at risk? What are the risk factors? We know these data from CDC. One of a very important factor, especially for cardiovascular disease, is the race. Black women being 3 to 4 times higher risk of dying from cardiovascular disease, and in general, pregnancy-related mortality, they are much higher in terms of their risk. And the other component is the age. As the woman ages, as you can see, over 35 to 39 is when the mortality goes up higher. So Black race and age is a common theme. When we look at the late maternal mortality rates for peripartum cardiomyopathy in particular, because that is one of the biggest groups that in the cardiovascular deaths, women who are older than 35 are twice as high risk for women below 35 to die of cardiomyopathy compared to younger women. Same thing is seen, same trends have been seen in California. And you can see that Black women are depicted in pink. And in each of these 3-year periods, Black women at much higher risk of dying of pregnancy-related causes. And then the third question when we talk about maternal mortality is, when does the cardiovascular disease-related mortality happen? What is the timeline? Data from US, the biggest part or the biggest trend in maternal mortality due to cardiovascular disease is beyond the conventional postpartum period. And that brings up, as Lisa had mentioned earlier, this is a very specific finding, particularly in cardiovascular disease. So this bundle, when we talk about implementation, not only spans obstetricians, but healthcare providers that the woman can present to, whether it's the emergency room or it is the primary care. So beyond the conventional postpartum period. And from California, you can see in here, the dark blue is while pregnant, lighter blue is 0 to 6 days, 7 to 42 days, and then beyond the conventional postpartum period. As you can see in here, cardiovascular deaths, 33%, 1/3 of them actually are beyond the conventional postpartum period, beyond the postpartum visit that a woman has. And a large proportion, again, is 1/4 is in beyond the 7 days after delivery, and so on. So postpartum period is the largest or the most important period where there are opportunities to prevent maternal mortality from cardiovascular disease. And we saw that data from California 2002 to 6, where the timing of cardiovascular diagnosis was also delayed. And this was a very important timeline. So if you look at the lightest bar on the right-hand side, the 48%, these were women who had died of cardiovascular disease. The diagnosis of cardiovascular disease actually was made at the post-mortem. Half of the women did not have a diagnosis prior to their death, and likewise 34% was in the postpartum period. And again, highlighting the fact that a lot of cardiovascular deaths are beyond the 6-week postpartum, and then a large proportion of them predominantly is cardiomyopathy. And this is aligned very well with the state of Georgia. Pregnancy-related deaths, 199 in this time period, 2012 to 17. Cardiac, 31%. Cardiomyopathy and other cardiovascular conditions. Cardiomyopathy, again, N of 18, and most of these deaths are beyond the conventional postpartum period. A very important piece of information as we talk about implementation and what areas to implement and what educational opportunities need to be in place to prevent this. No matter what the etiology of cardiovascular disease is, the ultimate presentation is either with heart failure or arrhythmia. Those are the two important distinctions whenever a woman had presented with a new diagnosis of cardiovascular disease. So in the next few minutes, we are going to focus on, we know that this is a big contribution from cardiovascular disease. How do we bridge this gap, taking the information from maternal mortality and then bring it and use it in a way that we actually do better in future? And it's important to realize that when it comes to cardiovascular disease, we have two types. One is there's a known diagnosis of cardiovascular disease. This is women with congenital heart disease, or they have some sort of arrhythmia, or whichever way they come in with the diagnosis. But the more important piece is the previously unknown or the new onset of cardiovascular disease. Sometimes it maybe is a mild lesion that may be relatively asymptomatic, may become more symptomatic during pregnancy, or it could be onset of cardiomyopathy. It usually happens during pregnancy or in the postpartum period. And another important point to remember is, especially from mortality reviews, the lessons that we have learned is that all of these women, a large majority of them actually had abnormal physical examination findings, or they had presented with symptoms before the sentinel event. Based on those lessons, Cvd Toolkit was developed by CMQCC. And this is for pregnant and postpartum women as a quality improvement toolkit. When we applied this algorithm, we have two algorithms. I'm going to go through them in the toolkit. The algorithm was applied to the 64 cardiovascular deaths. The detection rate was 93% in symptomatic cases. They would have been identified as screen positive or high risk for cardiovascular disease. And remember that orange graph or the timeline I showed you earlier, 50% of women who had died in this group actually did not have a diagnosis of cardiovascular or a suspicion for cardiovascular disease before they had died. They were actually diagnosed at autopsy. So the opportunity that we have is to identify women who are presenting with symptoms or history or physical examination findings. There are two algorithms that are included in the CMQCC toolkit. One is this one, where there are either red flags or personal history of cardiovascular disease without the red flags. We'll all agree if a woman is short of breath during your exam or at presentation, or they're severely symptomatic, their heart rate is 120 or above, or systolic blood pressure, these patients need to go in for evaluation. These patients need to be admitted and appropriately worked up. And likewise, if a patient comes in with a personal history of cardiovascular disease, this is another group that needs consultation with MFM and cardiology, and they need to be followed very carefully. How about the women who don't have red flags and do not have personal history of cardiovascular disease? As we know that this is a very small subset of women. However, we need to look at how do we screen all pregnant women? What are the parameters? What are the things that we can pick up and perhaps identify women who are at risk for cardiovascular disease? So this is the 4-bucket model that is in this algorithm, which is, again, symptoms. Symptoms, remember that these are self-reported symptoms. You don't ask the patient, but these are coming in. Patient comes in and she says, I'm short of breath, or I have palpitations or chest pain. Or if they have vital sign abnormalities listed here, or risk factors, or physical examination findings. The risk factors are older age, like we saw in all mortality reviews, older age, higher risk for maternal mortality, African American, pre-pregnancy, obesity, BMI of over 35 or above, diabetes, hypertension, history of chemotherapy, and substance abuse. Now, amongst these 4 buckets, if there's a physical examination finding, if as an obstetrician or in any area of women's healthcare, you listen to the heart and there's a murmur, or there are bilateral crackles on the lung exam, these women automatically screen positive. These are women who will need further workup, further consultations. Now, if we take these 3 boxes and there's one from each box, so a patient complaining of shortness of breath whose O2 sat is 95% and who is 40 years of age, those 3, one from each box, will make this patient screen positive or high risk for cardiovascular disease. Or if there's a combination adding up to 4 from any of these boxes. For example, if there's a woman whose heart rate is 110, systolic blood pressure, and so on, even from one box will be screen positive. And the recommendation or the guide from this toolkit is to obtain further testing, whether this is EKG, BNP, echocardiogram, and so on. And they need to be followed up and further consultations as indicated. So with that, I'll just briefly review the Ccoc bundle that Lisa had gone over very nicely. I think everyone should try to go to this website, safehealthcareforeverywoman.org, and review this bundle. It's way detailed. I just picked up a few slides, token slides to show during this. How is the cardiac condition defined? So these refer to the disorders of cardiovascular system that can impact maternal health. And we had a lot of debate as to what to include. And these are the cardiac conditions that are included in this bundle. Congenital heart disease, sorry for the typo, cardiac valve disorders, cardiomyopathy, arrhythmias, coronary artery disease, pulmonary hypertension, and aortic disorders or aortic dissection. And the 5 components, the readiness, recognition, prevention, response, reporting, and systems learning, and respectful, equitable, and supportive care. I won't go through this again. Lisa has identified the important points from here. I would just highlight 2 or 3 things. Just to have a protocol to identify pregnancy-related cardiac conditions in all practice settings, to make sure you identify specialists or individuals, healthcare providers that constitute the pregnancy heart team at your institution. After you know what the level of maternal care you are, so that it's appropriate for that patient. And have processes in place for referral, consultation, or transfer to another facility if you identify a patient with cardiac condition. In recognition and prevention, the most important piece actually here is, especially in the ED or the primary care setting, in a focused pregnancy and cardiac history is very important because the only way to really link that shortness of breath or fatigue in a woman, in a reproductive age woman who presents to ED, is the knowledge that this woman was pregnant 5 months ago or she delivered 6 months ago. In context, you'll be able to pick up a potential cardiomyopathy. And then in response, the facility-wide standardized protocols with checklist and escalation for management of cardiac symptoms. A lot of times as obstetricians, the symptoms of heartburn or chest pain, all chest pains are not cardiac, but you need to have that element of suspicion of cardiovascular disease. And an important piece is the transitions of care, as we're going to go over a little bit later. The reporting, again, the huddles, the post-event debriefs, as Lisa had pointed out, and then to monitor the outcomes and processing of the data obtained at each institution. And then we have to keep in mind for structural and social drivers of health, and to have open, transparent, and empathetic communication with the families and pregnant and postpartum people. And there's a lot more on there, so I'd encourage you again to go to the website and download the information. It's very useful how to report and systems and learning and all of those things. I just picked up a couple of slides. There are structure measures included in the bundle, and there are process measures that are included in there as well. One of the things is the standardized pregnancy risk assessment for people with known cardiovascular conditions. Denominator is patients with cardiac conditions who are diagnosed or who carry the diagnosis when they present for prenatal care. And then amongst those patients, those who receive pregnancy risk classification using standardized cardiac risk assessment tools by the time of birth admission. And the other optional process measure that is included is Cbd Risk Assessment among pregnant and postpartum people, all birth admissions, whether from sample or entire population, and amongst all pregnant or postpartum women, those with documentation of CVD screening using a standardized tool. There's only one CVD assessment algorithm that I shared with you, the CMQCC CVD assessment algorithm for pregnant and postpartum women. It has been validated in pregnancy-related deaths, and we have ongoing studies to get more data on a larger scale. So I'll take you to the last part of my talk, which is a universal CVD screen assessment. Going back to the same algorithm, this is the basis of CVD screening. We went through this, and what we did a couple years ago is to take this algorithm, and we created a dot phrase in our electronic medical record system with a drop down for each of these boxes, and we used to fill those boxes, and we screened women. We did it at our own institution here at University of California, Irvine, and also we partnered with Albert Einstein School of Medicine, and we published these data. I'm going to briefly share those with you. In this initial implementation, we had 846 women who were screened. Overall, the screen positive rate was 8%, 5% in California, 19% in New York. And 19% in New York has to do primarily with their African American population. There were 25% Blacks in their population that they screened. The challenge over in New York was the follow-up. We had relatively good follow-up, about 75% here in California, but only 30% in New York. And that's another opportunity. It's a barrier to access care in those clinical settings. Of those who screened positive, 30% of those who screened positive had some form of cardiovascular disease. And we have a list of things such as there were patients who had systolic or diastolic dysfunction on their echocardiogram. Left ventricular hypertrophy was seen in 4 patients. There was arrhythmia noted in 2, valve disease in 5, and need for cardiac medications, which was new after the screening, was 4, and a VSD was diagnosed in 1 patient. So there was a large number of these, or there was a spectrum of cardiovascular disease that would have gone unrecognized had we not screened these women for cardiovascular disease. We actually worked on this grant from Gordon and Betty Moore Foundation on developing cardiovascular screening measures for pregnant and postpartum women. The 2 measures that we worked with were the CVD Risk Assessment. These are amongst all pregnant women who come in, how many of them, what % of them actually got screened? And out of the ones who got a positive screen, how many got follow-up? So on this, during this process, and this was a multi-center project at UCI, UCSD, UC San Diego, and University of Tennessee. We integrated the CVD algorithm now into the EMR. clinicians would receive immediate score as screen positive, and then you click in for imaging, laboratory test, and consultations, and then the follow-up was monitored through EMR. So I'll share with you our screenshots from these from the EMR, from the EPIC build. This is how the screen would come up. In fact, any patient who was pregnant, there's a red flag on the right side that shows cardiovascular screening required. You click on this, it takes you to this screen. You click on this pull data from chart, it populates the vital signs, the risk factors, substance abuse, whatever exists in the EMR. The only thing that you have to put in is self-reported symptoms. If the patient did not come in self-reporting symptoms, you just click this button, say mark all symptoms negative, and the physical exam if you had a murmur or crackles. That immediately gives you a risk score, either not at risk, possible risk, or at risk for cardiovascular disease. For the purposes of this, we were only focusing on at risk for cardiovascular disease. So then the next step, it takes you to the order set. These are different variations. This is a patient who is not at risk based on these, and this is a patient at possible risk. And then this is a patient who is at risk because the oxygen saturations were low and there is alcohol use in the pre-pregnancy BMI and so on. So the ones who are screen positive, you click on that, you see the red flag on the right-hand side, follow up, place orders. You click on this and it takes you to a order set, EKG, BNP. It automatically assigns a visit diagnosis and a follow-up, and you click on those, and that completes your screening. You can decide what tests you want to order, and then you can refer based on the clinics. You can pick up, because we have more than one clinic that patient goes to. That completes the screening. Now, during the same time, we also have another NIH grant that we are working on right now, and this is at University of California, Irvine, and with Albert Einstein College of Medicine, because again, we wanted to have a representation of Black patients in our cohort. So we are looking at the various components of this Cvd screening toolkit and see how what is the best way in terms of predicting the positive screen in these women. At UCI in California, we have about 3% Black women, and at Albert Einstein, there are 30% Black women. So it's one thing that we screen for cardiovascular disease, but I believe that there are three areas that it helps with. One, it identifies patients who are at high risk. You do further testing, and then these women get appropriate follow-up. But I think equally important is the patient and provider awareness and education. The healthcare provider will include CVD in the differential diagnosis next time, and the patient is more likely to seek timely medical care if she had been screened at some point, especially if she was screened positive. And then there is an opportunity to modify risk factors, because most of the risk factors that are used in CVD screening are the conventional risk factors for cardiovascular disease as well. This may prevent cardiovascular disease in future. Patients may have healthier choices, and that may improve both maternal and fetal outcomes. And it's a continuum. It's pregnancy, it's the postpartum risk evaluation, and then the transition to primary care and to interconception care to be better equipped for the next pregnancy. There have been a lot of interest and a lot of excellent publications in this area, and one of them is this one, where maternal morbidity and mortality are getting to the heart of the matter. The pre-pregnancy, the pregnancy, and the postpartum care. I think that is where we need to fill in the gaps. The CVD risk during pregnancy will translate into CVD risk after pregnancy, and it doesn't stop with pregnancy or in the interconception period. I think it's all throughout the lifespan of a woman. And these are, again, beautiful illustrations from publications recently from Dr. Davis, Lindley, where it outlines the cardiobstetrics team and the patient, the importance of preconception, pregnancy, labor and delivery, and the long-term care. And it lists, they provide guidance to how you can implement in your own unit. With that, I'd like to stop by saying that cardiovascular disease deaths are preventable up to 70% and a large proportion of CVD deaths are beyond the 42 days postpartum. Most of the women who die of cardiovascular disease have underlying risk factors, and most patients who present with symptoms and or vital sign abnormalities in the postpartum period. So these are women who are at a very high risk. The degree of suspicion for cardiovascular disease needs to be there for these young women who may appear otherwise healthy. Thank you so much for your attention. And I know Lisa had mentioned we have some time for questions. We'd be happy to take those.
Great. Thank you so much, Dr. Hamid, for that fantastic presentation. We do have some time to open up for Q&A. I'd encourage anybody to put those questions in the chat, or you can certainly take yourselves off mute and ask those questions. And I think for me, just to pose a question to our hospital teams on right now, you know, when this is all fairly new. I know we've been kind of digesting this over the last couple of months with some of the maternal echo sessions that we've been having here in Georgia. But from your facilities perspectives, I'd love to hear, if there's big like challenges that come to your mind with, what was just presented today with, identifying those maternal cardiac conditions during pregnancy or during the postpartum period. Do you have any thoughts or, perspectives from your facility level? But I'll just pose a question to Dr. Hamid while everyone's trying to get warmed up with that. In Georgia, we have a lot of rural communities, and, our working group is specifically focusing on a product to support, acute management of the cardiac patient in those, low resource settings. And I know that, a lot of the EHR, I mean, that was fantastic to show that. Do you have any sort of best practices, or could you share any thoughts around sort of how does a hospital in those rural settings kind of get prepared to implement the bundle? What would be some key things you think would be important at the start?
Absolutely. Thank you, Lisa. I think it's important to screen women. In fact, when we started the first study that I shared with you with Albert Einstein, a couple of their clinics did not have EHR. So it was just a paper, a one paper with the check boxes listing all of the elements of the bundle or the algorithm in there, and they would just manually do that while the patient was waiting in the waiting room or as they come in. It's a little bit more labor intensive. Probably it takes about 2 to 3 minutes to fill it out, but there will be another way in a low resource setting that you could fill out. And if, say, the patient is screen positive, then depending on the availability of various testing, one of the basic tests included in the toolkit is the BNP, which is the B-type natriuretic peptide, which is relatively low-cost test and readily available because it's a kit. You can take it anywhere and do it anywhere. So it could be a starting point with a basic EKG and a BNP level, or it could be more involved where you think that patient needs an echocardiogram. But I think with one of the benefits of the pandemic that we have all seen in the last 2 years is the power of telemedicine. And I think that cannot be overemphasized. This is an opportunity where you could have a telemedicine visit. All that is needed is to have identify your level of maternity care, identify the local resources, and then once you exhaust those, have a plan in place so that you can access, for example, a cardiologist, or you can access an MFM through telemedicine.
Okay. So it looks like we have a few questions in the chat. Let's start up here. Are the instructions for the Epic build teams available? And did the folks in New York also use Epic, or were there other EMRs involved?
That's a great question. Yeah, the New York has Epic, and University of Tennessee has Cerner. So they have implemented in Cerner. The next part of the question, the instructions, what we are trying now, since we have two other health systems that are using our instructions, but as you know, that Epic varies in every institution. So there's a little bit of a tweak that each one of them is doing. So we are keeping a library, we are keeping instructions on how to build, and we have some screenshots that we have helped minimize the time taken by their IT teams to build into Epic. So I'd be happy to share information if anyone reaches out. We'd be happy to have you be part of the team and part of integration into the EMR. It does need IT support because what is done at, for example, at UCI, our system is exactly the same as University of San Diego. So we had the same IT team, so it was very easy. But at Albert Einstein, and now we are also working at the UMKC. They are also taking the information from our IT and trying to build this within a period of about 4 to 6 weeks.
Great, thank you. Another question we hear from Kathy. We've been working on a cardiology consult algorithm, and our problem is that we do not have an inpatient cardiology service, so it can be difficult to get a timely consultation. Also, it takes many weeks to get the patient an outpatient consultation with a cardiologist. What would you suggest to help us?
Absolutely. I think that is a real barrier because the clinics are, of course, busy. So I think using telemedicine, have an alternative, having perhaps an MFM who is interested in following up these patients. Technically speaking, if especially if it's a screen positive patient where they don't have a major diagnosis of cardiovascular disease, somebody needs to review those tests and counsel the patient. However, if this is a significant diagnosis of cardiovascular, then you'll need a cardiologist. And my advice on that would be try looking into telemedicine alternatives at your institution. Have that backup so that your patients don't have a delay in care.
Great, thank you. I'm just going through here. Okay, next comment. I tried to reach out to our only cardiologist to see if he would be interested in considering at minimum a risk assessment for those with severe hypertension, preeclampsia, or even chronic hypertension. Despite our Georgia statistics, I had no success in interesting him because his practice is so very busy. Do you have suggestions for me? We are a rural hospital. I wanted to see if he was open before I approached the OBs. Thanks, Lois.
Yeah, typically, that's again a very good question, and I think that's the barrier is that a lot of times, the implications of hypertensive disease in pregnancy is not considered as serious by non-obstetrics providers. And it has happened to us many times where a pregnant patient has come in, or immediately postpartum patient had come in with a blood pressure of 140/90. It's not a big deal at the outside of obstetrics. So I think there's a lot of education that needs to be there. But in general, once the patient is delivered and you have a preeclamptic or hypertensive or adverse pregnancy outcomes, I think there is a need to develop long-term follow-up for these patients. We are not there yet. I think the clinics and the interest and the groups need to get together, but there's really no incentive for most of the providers to do that, particularly cardiologists. And beyond the postpartum period, the obstetricians are, that you do the postpartum visit and then kind of, I think it's an opportunity, and I think we all need to figure out a way and to have a follow-up of these women. And I think that's where the non-obstetricians or the primary care physicians can help during the routine care after pregnancy or the yearly follow-ups, that they can actually focus on hypertension and other risk factors that could be modifiable through counseling or with medications.
Thank you. And Kathy followed up with her comment. Yes, we have an MFM who's well-versed and has been trying to take up the slack. So thanks, Kathy. And Dr. Ellis. Well, I'm going to read out your comment to the Grady people on call. We have been involved in meetings to set up an OB cardiology clinic so that we can make direct referrals to cardiology for our OB patients. The plan is for them to see patients while pregnant and then to see them in follow-up. Having Medicaid extension may be really helpful for us. Thank you, Dr. Ellis. You know, just hearing, there's a lot of questions about the consultation and referral component. One of the subgroups is working on consultation and referral, and looking to partner with our 6 regional perinatal centers to address this very important issue of timely referral. Any suggestions, Dr. Hamid, with criteria for cardiologist or a cardiologist team in order that takes maternal patients? What are some of the criteria that they would need to be an active, engaged referral? I know timeliness, right? Being able to see a patient within 48 hours. Are there any other things that we need to think about as we're thinking about consultation and referral?
Yeah, I think that's a real barrier. In general, you may want to identify a cardiologist and an MFM at your institution who is interested. That way you can have that point person follow up, and typically that probably would be the best way to do it. But I also am very excited to see that there have been tremendous interest in the cardio obstetrics. We have various work groups at the American College of Cardiology, American Heart Association, SMFM, Ccoc. There are fellows, cardiology fellows, who are super interested in learning about pregnant women with cardiovascular disease. And then we have obstetric or the MFM fellows who are really interested in knowing more about the cardiology side of a patient with cardiovascular disease. So one of the so there are many groups online, and there's this cardio obstetrics, the buzzword, and we actually, you know, the symposium that you mentioned by Dr. Al-Qayyam, the cardio obstetrics symposium, we have, you know, a lot of others that are interested. We do fellows in training case presentations on a quarterly basis, and I'm so excited to report that we have tremendous interest, a lot of fellows coming in. So I think I see that coming from the ground up. I see that the fellowship or the fellows are interested as they become practitioners. I think down the road we are going to see more and more who will be interested to take this challenge on. But as of now, there are some who are interested, and you're right, and in a community-based. So you need to identify. I think there's no real magic to that. You need to identify a cardiologist, and if you don't have a cardiologist, maybe a primary care physician, an internal medicine, a family practitioner, an MFM who would be interested to follow up these patients. I think we just need to create that network to make sure that we don't have gaps in that patient's care.
Thank you. Just want to give one more shout out to anybody on the call joining via phone. Please feel free to unmute and ask any questions. And if there's any remaining questions, please go ahead and put those in the chat. And I'll also give a chance for any of our maternal chairs, if they're able to stay on long enough. If there's any thoughts from, I don't know, Drs. Ccoc or Bird, if you are able to join today. I see Dr. Ccoc was on. Any questions or thoughts to share?
No, this is Missy Cotke. That was spectacular, and thank you so much for sharing all that you did. I know we're very excited about stealing shamelessly from all the work that you've done. So thank you for your willingness, and we're just really grateful you're here today.
Absolutely. Thank you so much. I think this is the work to share. This is to spread that, it's that. Yeah, so I'm glad that I'm really excited, and I'm so happy to see the interest and the kickoff. Congratulations, Georgia, you're doing great. I think you're gonna many others will take your lead. So I congratulate you for starting this up, and I wish that this works very well. You are going to come up with a lot of barriers, and I'm sure that will overcome, and down the road we'll have, this is my goal, my professional goal really, is to see that we screen all pregnant postpartum women for CVD, just like we do for diabetes and hypertension and for UTI, for example. I think it'll have a huge impact down the road.
Absolutely. Hallelujah. Thank you again, Dr. Hamid, for your amazing presentation today and your comments and thoughts. And thanks everyone for taking the time out. I know there's a lot of Zoom meetings, a lot of Teams meetings all over the place. So we appreciate your time checking in with us today. We are excited to continue to impact hearts here in Georgia. So please reach out. Please submit your interest form and just absolutely reach out to me with any questions. But just want to thank everyone and have a great rest of your day.
Thank you, everyone. Thank you.